Hello and welcome everyone. I'm Tina Walia and I'm pleased to be your host today. This evening, we're excited to present the latest in our webinar series on wellness titled Innovations in Cancer Therapy, Living with Hope. It is my pleasure to introduce our keynote speaker, Dr. Peter Lin, to you all. Dr. Lin is an internationally renowned speaker, and we are very grateful that he could make time for us today before departing for Europe. He's the Director of Primary Care Initiatives at the Canadian Heart Research Centre and has a busy family practice in Toronto, Canada. He's a popular guest on CBC radio and television discussing topics of health and wellness. Today, Dr. Lin shares with us his vast knowledge of cancer research and the latest treatments available. A very warm welcome to you, Dr. Peter Lin.
Thank you very much, Tina. So let me share my slides, and thank you for the opportunity to speak to this WOW convention. I think I've spoken here once or twice before, and you always put on an excellent forum. And I want to thank the organizers for putting this together and for inviting me back again just to talk about some interesting things about cancer. And thank you for the audience for tuning in as well. So I'm going to start off by talking about cancer. Cancer is probably the most scary diagnosis that we have right now. So if I told you you have heart disease, we sort of know what we're doing with heart disease, but if we tell you you have cancer, then many people are in shock, and a lot of people are thinking of all the horrible things, the hair falling out, those kinds of things. And the good news is that we have advanced quite a lot. So let's talk about cancer and talk about the diseases that happen. But I thought I'd start off with just one little funny. Is why do women live longer? Because we're always trying to figure this out. Women always live longer. And so this was a video that I saw, and I thought this might explain things quite well. So here she is, perfect. Everything is perfect. And then here he comes and boom. Okay, so nobody was hurt in the video, but you can understand that the boys may not last as long. So definitely there might be differences. But in terms of cancer, unfortunately, we do have lots of people that succumb to cancer. And let me just show you back a little bit of history. This was the original kind of operating room table. You can see it's made out of wood and there's a bit of leather up there. And these were the kind of operating equipment that we had. So these saws that very much look like carpentry. And so you can understand that our success rate for surgery was not very good. So people used to die of simple things like fractures and things like that, where you would have to amputate, or they had appendicitis and they couldn't save them. So very simple things that we take for granted now, we couldn't really treat back then. And then we went through the period of infectious diseases where we had dirty water and sort of sanitation issues. So people were having diarrhea, and then people were dying from that. So they wouldn't make it to a very old age. And then now, of course, we have the President Obama. The disease is not the Secret Service behind him, but it's the food that he's eating. And so therefore, we've now gone through the cycle of obesity. So this is what he looks like now that he's a retired president. So therefore, obesity in terms of heart attacks and strokes became the big deal. Diabetes, that's the current most popular diseases that we see now. However, with heart disease, we had to live longer. So we were able to fix the hearts and things like that. But then people lived long enough to qualify for cancers. Now she's smoking, and people always said, oh, you're terrible. She wasn't always a smoker. Actually, she was. This is at birth. See, she was smoking right there already. So all of a sudden, people were living long enough that we would now start seeing diseases like cancer, Alzheimer's disease, Parkinson's disease. Those are the kind of things that we're now heading towards. But don't worry. Every time we head into another area where there's a disease, people are very good, very innovative, and the doctors and the scientists are very good at trying to figure things out so that, again, we can, project longevity again for all of us. So don't worry, we will be able to handle cancer as well, even as we move forward. Having said that, cancer is a very scary word. And if you look at from the Cancer Society, what are the cancers that hit people? And there's this big, huge space missing. So if you talk about women, basically the big, huge space there is breast cancer. So that takes up, almost 40% of the cancers. And you could see that the second in command is colorectal cancer at around 10%. And then the uterus picks up some, thyroid, and then melanoma. So therefore, checking your skin is a good idea, because if you see a spot that's abnormal in shape or it's abnormal in color, it means that it's not organized. So what we're looking for those spots is it nice and organized? So an organized growth, a good civilization will have a nice border. It won't be all irregular. It'll have same color. So you don't have a patch of black and light colors, and it doesn't grow hair out of it. And it certainly doesn't bleed on its own. So these are the warning signs that maybe it's not a good patch of growth. So those are the things that could tip us off. And it's very sad if we miss something on the skin, because we can easily access it and see it. And for those that want to keep track, I've been telling people to take a picture of it. And the easiest way to do that is just to take a ruler and just put it next to your skin, next to that lesion, and then just take a photo. And the ruler gives you size, and the photo gives you time and date. So then you can scroll through a bunch of them, and you can actually see, has it been growing? Has it been changing colors? And that may be very helpful for your doctor if you say, hey, look, this thing used to be this small and now it's this big, and the colors are all abnormal, and you can show them on your smartphone. So perhaps that's some useful way of using technology and helping us in that fashion. So we'll talk a little bit about breast and colorectal cancers. For men, which one would you think it is? There's a big chunk missing here. And of course, that would be prostate cancer. And so therefore, again, in a similar amount as breast cancer for women, we have prostate cancer for men. And then number 2, as people guessed, colorectal cancer. It's that same color. It looks like poo color, I think. Anyway, so the thought is that is also the number 2 here. And here you have bladder cancer. I think that's because there are more people smoking, more males smoking in general in the past. And so therefore, smoking, those chemicals can increase bladder cancer. And you can see melanoma here again is popping up. So having a skin check is very important for you as well. In terms of naming systems, so for example, if we look at breast cancer, you might have seen these things on your reports, so family members that have it, you'll see the TNM system. And people ask me, what is this TNM? So T is the tumor size. So basically, it was very fundamental, because remember, when we started with cancer, we didn't know why the cancers came, but we can measure certain things. So we can measure the size in terms of centimeters. So the bigger it is, the bigger the number that we carry with it. And then if it breaks through skin and things like that, then that's a very bad situation. Then we talk about the lymph glands. So the lymph nodes, think of them as your police station. So the lymph nodes are your little police station, and there's a lot of your army cells in there. And basically, the lymphatics is like your sewer system. So basically, think about the roads and the sewer system. So the lymphatics are the sewer system. And basically, they collect all the garbage that's there. And these little lymph glands are sitting there checking the garbage to see if there's any bad stuff in there, like infection or weird cells. And then they will take them out. So that's why we have all these little police stations along this sort of lymphatic system. And once we're sure that that liquid is okay, it's actually returned back into circulation. So all these lymphatics come back, and then we put it back into the vein, and then we mix it all back up with your blood, and then we can pump it back out again. So think of that as the rainwater runoff, the sewage that we're checking to make sure everything is good. Now, if your lymph glands have been invaded by the cancer, then we can sort of tell you what stage you are. Like, can we feel the lumps and so on and so forth? And we can also count the number of nodes, like 3 positive, 12 positive out of so many. And so that's why for breast cancer, oftentimes you'll hear them say, we're going to go after the lymph glands in the armpit, because those are the systems that drain the breast. And so therefore, they're looking at the number of lymph nodes that are positive. Of course, we would love it if it's 0. No lymph nodes would be the most beneficial thing for our patients. And metastasis is a scary word that just means it's gone elsewhere. So it's no longer localized. It's now moved somewhere else. And so therefore, the strategy is a little different, right? So in other words, I can't just take out the lump, because there are cancer cells that have migrated elsewhere. So therefore, that automatically means we need to chase them with some other treatment, like chemotherapy in the olden days, where we try to chase them through the blood and get to wherever they're going and try to kill them off. And the traditional strategy of chemotherapy is kill anything that's growing fast. And so therefore, the cancer cell is growing fast, and we can kill it off. Unfortunately, your hair also grows fast, and the lining of your mouth also grows fast. So therefore, there were complications of that strategy where you just kill things that grow fast. So you lose your hair, and then you get these ulcers inside your mouth. And thankfully, the treatments have become much better as we move forward as well. This is a mammogram. So way back, all we did was we felt things. So doctors, patients would check themselves. We didn't have mammograms before. And then when mammograms came, we were able to see inside, and we could see things that we couldn't feel, maybe, right? So you can see these calcium spots, which means there's a war fighting on there. And so therefore we can see these things, and therefore we could detect cancers earlier. So one of the earlier questions was, does this actually decrease death, right? So are we just picking up the disease earlier, but the people are still going to die? Like, in other words, we're just finding it earlier and they're going to continue on that same path. Or by finding it earlier, are we able to alter the course of death? And so they did a huge study where they tracked all these people. This was in the US, and see, this is sort of the death per 100,000. And what you can see is over time, this is over a long period of time, you could see that the death per 100,000 from breast cancer was very, consistent. And then when they introduced mammograms somewhere around here, look at what happened to the curve. So instead of just being consistent of 70 people per 100,000 people dying, it started to go down. And this was I think it was the most beautiful graph that we've ever seen, because a screening test, by identifying people earlier, could actually alter the course of somebody's life in the sense that they can live longer. And so there was a 42% decrease in death rates if you were doing the mammogram screening. And so therefore, yes, mammography, doing this funny x-ray thing where women do not like this, where there's a squeezing action happening, and they need to squeeze so that they can get the breast tissue into one thin layer. And that way, when they shine the x-rays through, they can see if there's any lumps or anything like that that's getting in the way. And basically what happens is that when the cancer is there, the x-rays can't get through as easily. And so therefore, if the x-rays can't get through to the film, then it shows up as a white spot. And so therefore, we can see these things as long as we squished everything very nicely. And unfortunately, that was very uncomfortable. However, we were able to save, so you can see, let's say 500,000 lives during this period of time of mammography. Now, having said that, at the same time, we might have caused some anxiety in people, because what would happen is that we started saying, that kind of looks like cancer. And so maybe we should do a biopsy and we should do all these things. So there were some situations where it kind of looked like cancer, but when we did the biopsies, it wasn't cancer. And in those situations, it means that we've done a little bit of extra harm to the person because our screening test is not perfect. Now, having said that, if we always waited until we were 100% sure that it was cancer, like a big, ugly lump, then we're going to miss those earlier cancers as well. So on the one hand, we don't want to do unnecessary things to people. But on the other hand, if we set it to the point where it has to be this big before we consider, biopsies and things like that, then we would miss a lot of those early people that we can help save. So we're always walking that balance of, we want to screen so that we don't miss anything, but we don't want to put somebody that doesn't have cancer at risk of all these other procedures that we're doing. So it's always a balancing act that we're trying to do. Now, if you saw this one, I think most of us would figure out that doesn't look normal. So the question is, how about earlier? Like if you had images of this person earlier, it might look something like this. Now, because you saw this, you now know that this is abnormal, right? However, if you go back a little further, you'd be hard pressed to pick this area out. And so therefore, if I was looking at this mammogram right now of this person, I wouldn't say that there's anything sitting there. And so therefore, we might miss these earlier diagnostic moments. And so that's why people are now looking at artificial intelligence. I know we've heard the AI word thrown everywhere, but I think the concept is we can train a system to do things repetitively. And that's not really AI. AI is where it's thinking, right? Or I shouldn't say thinking, but it's collecting information and then trying to put things together that wasn't put together before. In this particular case, we could train a system where it's looking for specific patterns, like let's say crossing of certain things, or an area where there's more calcium spots, and that would be an area of focus. So we can train the system so that an expert would say, these are the things that I'm looking for as a super expert in mammograms, and therefore the machine can then do the same thing. But the only difference is that the machine will do it day and night, and it doesn't get tired. Whereas if you're sitting in a dark room looking at these pictures, you get tired, right? So sometimes you might miss one, you might not see all of it, and you forgot the part at the top or something, this little spot here. So whereas the machine is not going to get tired, it just keeps doing the same algorithm. So perhaps these kind of uses of a machine in order to read it may actually make it more consistent. So you don't have to have the best X-ray person reading it. The key is that the machine will be at that expert level. So then everybody is getting a good reading of the mammogram. So it doesn't matter where you are in the world, you'll also get the right answer. Prostate, okay, I'm sorry to show you nasty pictures, but here's the prostate gland. It's deep, deep inside, so it's not easy to reach. Here's your bladder. And so basically the bladder fills up and then the urine comes through this tube. And you can see that the prostate gland sort of wraps around the bottom of the bladder. So basically the bladder has a tube going in, and this is like a donut that goes around that tubing. And for those people that have enlarged prostate, what basically happens is that as the prostate grows, it starts to push in on this little tube. So in other words, it grows outward, but the tube gets crushed. So therefore, when the tube gets crushed, it basically becomes very hard to urinate. So therefore, a lot of people will say, I stand there and nothing comes, and so on and so forth. So people start finding that there's flow problems. Now, interestingly, when people have those symptoms, we start thinking, do they have prostate cancer and things like that? The good news is that most of the prostate cancers hang out on the outer edges of the prostate, most of them. And so therefore, they don't really touch the tubing. So if you have blockage kind of feelings, chances are it's not the cancer. It could be a very large cancer as well, but more likely it's this prostate getting enlarged. And so therefore, we have lots of different surgeries and things like that can help with that. The other problem is that because it doesn't cause a lot of symptoms, people thought, well, I don't feel anything bad down there, so there can't be any cancer going on. And so therefore, they don't actually get. So therefore, we try to check. And so in the olden days, when I was a medical student, the only way to reach the prostate is unfortunately through the wrong end of your body. And so therefore, we put our finger into the butthole, and then we're trying to feel the prostate. Now, you can imagine that if it happens that the prostate is sitting right there, we can feel the lumpies and things like that. If it's sitting a little bit more in, it's a problem. If it's sitting on the front surface of the prostate, I'm only reaching the back. So it's like rubbing the back of my head and then trying to figure out if there's a cancer in the front of my head. Well, I won't be able to do that. So you can understand that the finger up your rear end wasn't the best test. And so people were constantly looking for a better test to do that. It's useful, but it's not going to be able to pick up all of the cancers that are in the prostate. So along comes the PSA test. Now, the prostate-specific antigen it's an enzyme. It's an enzyme that's made by the prostate, and it's there to break down sort of thick fluids. Okay, so for people that want to know, basically when the sperm and the semen get together, the fluid that gets together, it's actually quite thick, and so therefore you need enzymes to break it down to make it more fluid. And PSA is actually the enzyme that breaks that down. And so people, when they were looking at prostate cancer patients, they noticed that this number is very high. And so therefore they gave us some ranges. So they said sort of 0 to 4, unlikely to be prostate cancer. And in this case, this person is like almost 10. And so therefore people said, now we have a tool to measure that. The problem with it is that PSA is made by normal prostate cells. So this is not specific to the cancer. So it's not a protein that only the cancer makes. Instead, all prostates can make this. So you can understand the problem with that. There might be other things that could raise this PSA number. So for example, if we look here, yes, prostate cancer is there. In other words, if you have cancer, you're going to have more cells that are growing like crazy, so the PSA will be very high. However, if you have an enlarged prostate, just by having more volume of prostate cells, they're going to make more of this PSA, so your number will go up as well. Now, this one, the number goes up very fast, right? It's going to keep jumping as this thing is growing, whereas this one is a nice, slow, gentle increase. So we can sort of tell something by the speed of things. So that's why I always tell my patients, I say your prostate, your PSA test is 0.5. Now, for some reason, my patients can't remember 0.5, but I said, you're only 50 cents. You're not even $1 yet. You can't even buy anything at a dollar store. You're only 50 cents. Then they kind of click in that it's 0.5, which is 50 cents. And then I tell them that if next year, for some reason, I tell you you're $2, even though up to $4 is normal, you're going to say to me, wait, I was only 50 cents. How come I'm $2 all of a sudden? Because that rapid change is going to give us a hint that something is going wrong. So PSA, if you're getting it done, make sure that you keep track of the number. In other words, you can see if there's these jumps. If it's nice and gentle increase, like 50 cents, then 60 cents, then 70 cents, no big deal. It's these rapid jumps that we worry about. You also can get rapid jumps if you have prostate infection. So if you have an infection of the prostate gland, then everything is going to be swollen and the cells are releasing lots of this PSA. So therefore that number will go up. So that's why a lot of times they'll make sure that you don't have an infection before they start the path of, you've got prostate cancer. Ejaculation recently will also affect it. Basically, As the ejaculate goes through the prostate, it rubs the prostate, and therefore that can make the PSA go up a bit. So therefore, maybe we should avoid that. Digital rectal exam. So if I put my finger in there and squeeze it, that will make the number go up. And if you sit on a bicycle or anything that's giving pressure down at the bottom, or you're bouncing up and down, we can actually change that PSA number as well. So the bottom line is, if you want to get a PSA done, let's control the things that we can. So let's take out these 3 things at the bottom. So don't get a rectal exam, don't sit on a bicycle, and don't have an ejaculation within 48 hours. So let's get rid of those things. And then hopefully we know whether you have a prostate infection, so we can get rid of that one. So now you're just between an enlarged prostate or cancer. And for that one, if we see the rise being very gentle, that's probably enlarged prostate. Cancer will be the ones that sort of jump up a bit more, and the numbers will be higher. So we can make the test better by eliminating some of those other things that might make it confusing. This is actually a spot PSA test. You can do this at home. I was looking at this thinking it's a COVID test, but it's basically the same concept. So you have to take blood samples though. So this isn't a swab or anything like that. I would love it as a swab. So you take blood samples, you put the serum in there, and then you can, it basically runs across just like a COVID test. And if the PSA is there, then it tells you how much PSA, and certain lines give you certain numbers that you can use thereafter. You're going to hear about MRI scanning because people said, okay, so the finger isn't going to cover the whole prostate. The PSA is not perfect. It's not specific for prostate cancer. So can we use imaging? So they use MRI scans now, and they take a bunch of different images. So sometimes they take different settings on the MRI, and they combine all those images together, and it can tell you whether there's a lump here or there within the prostate gland. And so it does 2 things. One, it confirms, is there a lump in the prostate gland, yes or no? And it tells you where it is. So if we need to do a biopsy, we can guide it. It's in the front part of the prostate, the left side, right side, and the back. So we can actually guide it, as opposed to right now, we just stick something up there and we just take needle samples across the prostate, so we can actually go after the specific lesion. So you'll hear more about this MRI scanning as being a good extra tool for prostate. What about the therapies for prostate cancer? And this is just to show a concept. So one is I can go and kill the cells, right? Hit things that are growing fast and knock them out. Another one is basically I decrease something that makes them grow. And in this case, the male hormone testosterone makes prostate cells grow because they have a lot of testosterone receptors. So if testosterone hits those receptors, it makes the cells grow. So the whole goal is to remove testosterone. And so therefore your pituitary gland up here is the starting point of making testosterone in your body. So we have ways to block that right at the source of the head office. We can block it at your adrenal glands, will produce testosterone. So we can block it there as well with medications. And we can actually block the receptor of the testosterone. So where the testosterone hormone is going to operate, we can block it with medications as well. This is the first generation and your second generation medications. So therefore, the whole concept is to get rid of testosterone. Just like in breast cancer, the whole concept is get rid of estrogen. Estrogen will make the breast cancer cells grow. So we want to deplete you of your estrogen. So in other words, depleting the signal that's causing the growth is one way of doing it. Killing the cells directly is another way of doing it. And so we have different ways that we can go after the cancer cells. What about bowel cancer? So everybody knows about the poop test, right? So recently, for those that qualify for the FIT test, it's a slightly better test and it's mailed to you. So I'm always wondering what the mailmen are thinking as they pick up the mail to send it back. So these are stool samples looking for blood. So if you have a colon cancer and if it's leaking blood, we can detect it in the stool sample. And so therefore, this is one way of doing it. But you can understand that if you have a cancer that's not bleeding, we'll miss that one. So it's not perfect, but it's a good tool for us to quickly screen many people over a couple of years. The best screening thing is to look into the colon itself. Okay, so here's another principle. So instead of using a scan or anything like that, you pass a tube, you go up there with a light. So this thing has, it basically has a light, it has a lens so that you can see through it. It has something where you can pump water in there so that you can wash the area. And then you have a port to put in instruments like little forceps and snares and things like that, that you can take out these little tumors. And so therefore you can actually do a polypectomy. Ectomy just means to remove. So you're going to remove a polyp, and a polyp is just anything that grows. So you can see the thing comes in, and here's the instrument with like a little wire net around it. and then basically they tighten the noose on it, and then they basically can cut it with some electricity. Now they don't let it go like this. This looks like cauliflower that's going to keep going. This thing actually hangs on to this thing, and then you can pull it back out. And then as you pull it back out, you can then send it for pathology so that they can figure out, is it cancerous, what kind of cancer, what stage, those kinds of things. And that's really what we're doing. And the good news is every time we remove one of these things, it takes about 5 years to grow a new one. So colon cancer doesn't grow very fast. And so therefore, every time you remove one of those things, you reset the clock, and then now you have to grow yet again. And here you could see, which stage would you like to be at when you discover it? Do you want this big, huge one, or do you want this tiny little bump? So obviously, the earlier we detect, the better it is in terms of survival. And that's why we have screening programs for colon cancer. I like this picture. It's got the C in it. So what increases your cancer risk? And so this one took us a long time to figure out. So I'm going to show you probably like 50 years of research in like one slide. Okay. So I'm not doing justice to this. So you guys all remember high school, here's your DNA, the little chromosomes that's sitting inside each one of your cells. And if we were to look at one of these chromosomes, it would look something like this. It's all curled up and it looks like these Y shapes. But if you uncurl these Y things, you'll get this little stringy thing. And this little stringy thing, if you keep unwinding it, you'll get these things. And then if you keep unwinding it, you'll actually get that DNA, that double helix business. And if you keep looking at it very closely, you'll see that there's certain letters. Now, there's actually not letters there, but these are chemicals, okay? So these are chemicals that are paired together. So a G chemical and a C chemical always paired together, an A and a T is always paired together. So with those 4 letters, we can now make all of the stuff in our body. So basically by sequencing in different ways, we can make sort of statements or sentences. It's kind of like letters, right? So if you have letters, you can jumble the letters and then you can make words, and then you can make the words into sentences. Sentences become chapters, chapters become books. And so that's basically how your DNA works in terms of storing that information, and all based on these four letters. And it's actually only 2 pairs, and it's the order that they're in that will govern what happens in your body. What happens if I were to zap this? In other words, I destroy this or I change it. So you have a mutation. So let's say there's an A and T there, but now I stick in a G and C instead. So now I've replaced it. So what would happen in that situation? Then we have a mutation, and the mutation can then lead to things going wrong. So maybe this thing is coding for protein and you're not making the right protein. And so without that protein, then a disease might come. Or without that protein, the cell decides to grow forever, and then that would be cancer. So you can see that if we destroy the blueprints, that would be a problem. And so the first thing that we figured out was radiation. Radiation can destroy the blueprints. So as Madame Curie, Dr. Curie figured out, as she was discovering radiation, she was zapping herself and she was damaging all sorts of things. So the radiation has enough energy to go and knock out that DNA. Even though it's tightly wound, it can go and knock it out and then alter it. So it could damage it completely, and then you're hoping that your repair system will repair it, or it could just knock out something. So in other words, change the position of something. And then you start having all of these different diseases. So with radiation, you can get more breast cancers, more blood kind of cancers like leukemia, thyroid cancers, lung cancers, et cetera, et cetera. So UV radiation is the energy from the sun. So basically, to go and knock out DNA, you need high energy. Radiation, X-rays, high energy. UV light from the sun, high energy. That's why you heat up so much. It's depositing that energy in your skin. And so you can imagine that the cells are getting a lot of energy and their DNA might be damaged. So that's why we like to avoid these high energy situations inside your body. Smoking, huge, right? So basically you're lighting a fire and then breathing the stuff that's coming off that fire. Like, of course, nothing bad will come from that. So we know that cigarette smoke has about 4,000 different chemicals in it. At least 50 of them cause cancer, at least, okay, that we know about. And I'm sure there's many more. So therefore, with tobacco use, with those 4,000 chemicals, it goes all over the place. So therefore, you can have cancers in these particular areas, not just in the throat area. Because we used to think, the smoke hits the throat, it hits your lungs, and you get lung cancer, that kind of thing. But then I was thinking, cervical cancer, unless you're smoking in the most unusual way, I don't know how that happens. It's because all those chemicals go through the blood. And by going through the blood, it can reach many different organs. It can reach your bladder, your pancreas, stomach, etc. So that's why smoking is one of those things. We need to get rid of that one, because you're now
increasing the chance of damage in the situation. I love this glass of wine. I only have one glass, she says. And so the problem with alcohol is that it can increase all these cancers. The bigger the bubble, the bigger the numbers in terms of the cancer. So you can see all the way down the track, you can have cancers, and including breast cancer in women. So obviously alcohol is also doing something else as it's entering into your body and moving into different places as well. Hot tea. So I was very saddened to see this, hot tea. So if you drank more than, 700 mils or more of 60 degrees or higher temperature, if you compare that to those people that did not drink the hot tea, there's a 90% increased risk of cancer of your food pipe, your esophagus. And it makes sense, right? If you have something damaging it, then now the cells are damaged. So now the cells have to divide and make another copy of themselves. Now, during that copying process, that photocopying process, we have to take the DNA, stretch it out, make a copy of it, and then make sure that it's the same on both sides. You can understand that you can make mistakes. So if you make mistakes, then now you've introduced a mutation, a change, and that could lead to cancer, for example. So that's why we don't like things that are constantly being damaged. So let's say you have an ulcer on your leg, skin is not healing. If it's constantly under damage, you're constantly sort of getting the cells to divide, make photocopies of the DNA. And so now you might make mistakes and therefore increase cancer risk. So anything that doesn't heal, we get a little bit nervous about. Well, this is the US Army, very relaxed. They're no longer the fighting machines that we remember. And it turns out that if you have immunosuppression, so if we wipe out your immune system, you're more likely to get cancers. And the reason for that is because your immune system is not only defending against viruses and infections, but also abnormal cells. So when those cancer cells pop up, your body says, no, that's not me, so I'm going to attack it. And so that's why if your immune system is not working well, then you're at increased risk of letting those cancers continue to grow. And so that's why we pay attention when we start giving therapies that wipe out one area of your body, because that might not be able to serve the other area. So we pay more attention to these people because obviously they need certain medications that we have to give them that makes their immune system go down. And so we just monitor more carefully in them to make sure that they don't develop cancers. The Human Genome Project, you guys know very well. This is where we basically looked at all the DNA of people and put it together and sort of said, okay, this part is for hair, this part is both bone. So we figured out which components, which genes are making what protein and controlling what. Because basically all of us is made from the DNA. So the DNA is the blueprint. And from the blueprint, we will make all of our proteins, our skin, hair, everything, and then put us together. So basically, all the blueprints are inside every single cell. What happens if those cells mess up the chromosomes? Remember those little chromosomes that I said? So here's chromosome number 9, and here's chromosome number 22. What happens if these pieces got swapped? So when we were making the cell and we're trying to make photocopies and everything else, and we're pulling them apart, what happens if these two ends got swapped? And so therefore, this guy would end up having this orange bit, and this guy would end up having this purple bit. Now, these codes are not right. So the blueprints are no longer correct. And unfortunately, with this little flop, if that happens in the bone marrow, then you get one type of leukemia. And so therefore, when these changes happen, the blueprints are no good, and therefore things will therefore go in the wrong direction. Angelina Jolie, you heard about her, right? I think you might have remembered the BRCA gene or something like that mentioned. So BRCA1 and BRCA2 are enzymes that help you repair DNA. So remember when I said you damage the DNA with radiation or sunshine or whatever, then your body has a way to repair it. So to take out the bad part and put in the good part, okay? BRCA1 and BRCA2 are genes that code for that enzyme that will do that repair process. And so if you have an abnormal repair process, then your DNA gets damaged, but it doesn't get fixed. And so therefore, if you keep accumulating damage, now you're changing the DNA, changing the DNA, changing the DNA. And then all of a sudden it may change to the point where it starts to grow on its own. And so therefore she has decided to have her mastectomy because she doesn't want breast cancer. So remove the tissues because she's at about, I think it was 80% risk of having breast cancer. So that's the kind of craziness that we have. Now, better yet is a way to give her back the right DNA repair gene. So now you know how we've been doing the mRNA, the messenger RNA vaccine, and we all heard about it, that this is the blueprints to make the spike protein and all that kind of stuff. Well, could we give you the blueprints to make the correct BRCA gene, in which case you'll make the right enzyme and then you'll do repair. So this is the kind of stuff that people are thinking about as we move forward in terms of how to fix some of these people from their birth defects, in other words. HPV is one of those viruses that we've seen. There's actually about 40 of them that are transmitted sexually, but there's 200 versions of them. And some of these viruses can cause cancer of the cervix, right down in the women area. And the reason how it does that, it goes in and it alters the DNA. And so therefore, the virus, for example, in this case, it's HIV virus, it can incorporate some of its own code into your DNA code. So now for sure, we are altering things, right? And so therefore, could that alteration then lead to more disease and perhaps even lead to cancers and things like that as well? So we know that in HIV, they have a particular type of skin cancer. And so the thought is by incorporating this thing in there, you've now altered the DNA. So now you're more likely to have cancer. So infectious diseases may be a problem as well, right? In terms of cancer. We've all learned about COVID and everything else. But in this case, these are infections that have been linked to cancers. So Epstein-Barr virus, so this is the EBV virus, has been linked to this type of lymphoma. H. pylori, which is the germ that causes ulcer, has been linked to gastric cancers. HPV, like we just talked about, has been linked to cervical, anal, oral cancers, all of these different types of cancers because the virus can get into the DNA and change it. And hepatitis B and C has been linked to liver cancer as well. So in other words, we have an infection that can alter our DNA and therefore cause cancer. So can we do something about it? In this case, this germ, this H. pylori, we can give you antibiotics to kill it. So therefore, if you have heartburn, we check you for H. pylori. If you have that, we give you the antibiotics and this sort of whole bunch of pills kill it off, and then your risk of ulcers or gastric cancer is reduced. HPV, basically, we can give you a vaccine. So now there's a vaccine against this virus. So if you get the vaccine, then you don't get the virus, and then all of these cancers would not be in your future. And for hepatitis B, at least, we have a vaccine that we can protect you against hepatitis B. So therefore, you don't get the virus, and then you don't get the liver cancer risk. Hepatitis C, we don't have a vaccine yet, but we now have good medications to treat to get rid of the hepatitis C, and again, lowering your risk of liver cancer. How do we find these cancers? Traditionally, we wait until the thing grows, and then you have some symptoms. So in this case, you'll be coughing up, and then sometimes there might be some blood, and then we say, oh, there's something in the lung, and then we go and take an x-ray. So we look at it as a very mechanical way of doing it. This is a little dog that can smell, I don't know how many hundreds of thousands of different chemicals. And so they've now trained dogs to, sniff out, different cancers, bladder cancers, lung cancers, and things like that, because the cancer cells are making chemicals, and those chemicals might have a smell to it. And so therefore, it might be of some interest that we have dogs. So I was always joking that one of the screening ways in the future will be there's a hallway, and it's a whole bunch of dogs. Each dog is sniffing for a different cancer, and you just walk down that hallway, and at the end of the hallway, the dogs will tell you whether you're good or not. That would be the most cost-effective, and I think the most enjoyable kind of screening process where you get to meet a whole bunch of dogs. Liquid biopsies has been catching people's attention. This is the idea that can we take your blood and look for tumor cells? So originally they said, can we look for cancer cells in your blood? And we realized that whole cancer cells, it's a hard time for them to get into your blood. And so therefore they said, instead of looking for the whole cancer cell, can we just look at chromosomes, chunks of the DNA? And so now we have the ability to look for chunks of these things and separate out what's good ones and what is your tumor. So now we can find cancers early this way. Before the lump shows up, we can detect this. We can see if the surgery works. So let's say you take out the lump and all of the DNA stuff is gone, then you don't need chemotherapy. Did the chemotherapy work? If the chemotherapy works, this stuff should go up because you're killing it, and then it should go back down because now it's all gone. So the thought process is that this test might be very helpful, and also looking at whether the cancer has come back. So we can just do the test once a year, and then if we see the thing go up, it means that the cancer is back. So something like this is on the horizon. So you're going to hear more about this as we move forward. Chemotherapy, you remember, you just kill the things that are growing fast. Not a good strategy. We now heard about all these drones in Ukraine, very targeted, and that's where we're heading. And I want you to introduce you to Layla. She had lymphoblastic leukemia. She was had stem cell transplant and bone marrow things, had every procedure, was going to die. And so what they did was they gave a special treatment. It's called CAR-T therapy, where they basically had donor cells. So a donor gave his army cells, and then they changed the genetic coding, and they turned off some genes and they turned on some things so that basically this thing can go and kill it off. And she's alive and well. after a year and a half of this therapy, when basically people thought that she was a goner. So these are the kinds of things that we're thinking about in the future. And how should you prevent things? I'll quickly finish with the cookbook. So your DNA is like a cookbook, okay? And so certain chapters will be open and certain chapters will be closed in your cookbook. And so basically, some things will lock off cookbooks, some things will open cookbooks. And the question is, if there's a bad cookbook, a bad recipe, if we open it up, then that might cause disease. So for example, smoking tends to open up certain chapters of your cookbook. Other things may close the chapter. So this is a good protein, but I've closed that recipe. So now you don't make that protein. And so therefore people might get into trouble that way. Tea and toasters, please eat your protein, because we've been talking a lot about protein. We need these ones to be eaten. You have to eat this into your body. So if you're missing these things, you won't be able to make those proteins that we talked about repair. And so if we are trying to repair radiation from the sun, let's say here's a little damaged part on your DNA. We have a guy that comes in here and cuts it out. It'll cut it out, repair that piece, and everything is brand new again. What happens if you don't eat enough protein? Well, then you don't make these little enzymes. So if they're not there, then you don't get the repair. And you can understand that that would increase your risk of all sorts of cancers and things like that. This is stress, okay? So when you're under stress, it's not a good thing. When you're under stress, your whole body is now working very hard. And so all those proteins that we need to keep the body working, you're making them at a very, very fast pace. And so there's a chance that you're going to make mistakes. And so if we make mistakes on these proteins, then they're not doing their job, they're not doing the repair, then we're going to start to age, we're going to start to have more cancers and things like that. So therefore, I think we need to be careful about being overly stressed in our lives. And finally, I just want to show you this picture. So this picture is a frog and a horse. I think you can see that. And the question is, are they really two different animals? So if I start to turn this thing for you, you can see now they're actually both frogs. So one of the thoughts that I had is, could mistakes in those making the proteins be both the basis of aging and for cancer? So in other words, we're too stressed out, we're making too many proteins, we're not eating the right thing, so we don't have the right proteins. And so therefore, we have all this disease. So perhaps what we need to do is do some simple things, right? Slow down, calm down, don't worry, don't hurry, and perhaps eat well and sleep well might round us out. So on the one hand, we've got science that's trying to help us in terms of fighting cancers, finding it early, detecting it, things like that. On the other hand, we need to do our part by slowing down the damage process. So definitely no smoking, no alcohol, no bad things, but maybe we need to do more of the good things as well. Less stress and more sleep, those kinds of things may be more helpful to us. And so never give up. I love the attitude of this little salamander. He's not going down without a fight. So therefore we should also be the same in terms of how we fight for our lives by making sure that we don't get cancer by living a good life right now. Anyway, thank you very much for staying awake and for your time. I will stop sharing my slides and I'll turn things over to Tina.
Thank you, Dr. Lane. Your presentation on innovations in cancer therapy has been an eye-opener in so many ways for me, and I'm sure for our audience as well. Thank you once again. Now, moving on to the Q&A part of the webinar, I would like to invite Dr. Sudhi Devanesan, President of Trevo, to moderate the Q&A session.
Thank you very much, Tina. And thank you so much, Peter. That was an amazing, amazing talk that you gave. You made it so interesting, so engaging. And we are all much more educated after your talk. Thank you so much, Peter.
Thank you.
Peter, we have a few questions. One of them was, what is the best method of imaging for breast cancer, particularly if there have been breast implants? Do breast MRIs or thermal imaging, are they superior?
Yes. So when you have implants, you can have the normal mammogram, but unfortunately the squishing action, everybody's afraid, are we going to make the implants leak? Okay, because we don't want the material in the implant leaking into the breast tissue, because we've heard about a lot of bad things of inflammation and things like that that go on. So thankfully, with the MRI scanning, there is no compression. So the MRI, you just lie in the machine will then use magnetic fields to kind of line up your water molecules and then release them. And during the release, they can measure the energy and therefore create pictures that way. So now, even for women without implants, they're thinking about MRI scanning as well. The only problem is that it takes a lot longer. So when we do a mammogram, it's basically horrible feeling, but then it's a fast radiation at that point, like an X-ray. Whereas an MRI takes time. So you're doing the magnet thing. So therefore, the time of it becomes a problem. But certainly people with implants using an MRI scanner would probably the best way of doing it without having to do the squishing action that we're talking about. One thing that you can do is monitoring yourself. It's actually improved because with the implant, we've actually thinned out the breast tissue. So when you don't have an implant, the breast tissue sort of is very globular, so it's hard to feel things. But when you have an implant, it's almost like having a board on the inside, and now you're pressing against the lumps, against this more solid surface. So physical checking is also better in implants, but definitely the MRI would be better than the squishing of the mammogram.
Thank you. Thank you, Peter. A question about complementary therapy and cancer. Is there any evidence that complementary therapy helps?
Yeah. So unfortunately, in complementary medicine, they don't do any studies like to the level of the things that we do in Western medicine, for example. And so because of that, it's very hard to say you should use this or not this. Also, sometimes complementary medicine may go against what your chemotherapy is trying to do. So in chemotherapy, unfortunately, it's trying to create oxidation, trying to create damage to the cells, whereas complementary medicine is a lot about protecting your cells. So if people are taking complementary medicine along with their chemotherapy, it may defeat the chemotherapy's purpose, right? The chemotherapy is there to kill, whereas the complementary medicine is there to protect. So therefore, if you are going to use complementary medicine, you have to tell people that you're using that and whether it's going to clash with the treatments that you're getting. Unfortunately, they haven't done large clinical trials, and it's because nobody owns that complementary medicine, right? So if you're talking St. John's wort or whatever the therapy is, there is nobody that owns that. And so therefore, nobody has a vested interest to spend, $10 million to do this study properly. So unfortunately, we don't have that. But we have a lot of our chemotherapeutics coming from the Yule tree and the bark from the Yule tree. So in other words, Western medicine is looking at nature, but then the difference is they purify the active ingredient that's doing the work. Whereas in true complementary medicine, they tend to take the whole thing. Like, for example, ginseng, they take the whole ginseng, not the component of it. And so therefore, it makes it not pure, and therefore the results are harder to interpret. Whereas we have gone to nature, taken things out, purified it, and used those specific elements in chemotherapy.
Thank you, Peter. A question about breast cysts. Can they turn into malignancy?
So the good news is that if it's truly a cyst, then that's water and there's a little bubble. It's like a balloon with water in it. And the good news is that breast cysts do not become cancerous. They are just fluid collecting inside. Having said that, if they say breast cyst and there's stuff in it, then we get a little nervous about the stuff that's inside. So if it's just a simple breast cyst, the only concern that you have, if it swells up, it might cause pain, it might get infected, but it will not turn into cancer. The best way to monitor breast cysts is actually ultrasounds, right? So ultrasound sees breast cysts beautifully because the separation of the liquid and the sound going through there is very nice. So you can have very nice pictures, and you keep an eye on the size as well. And just make sure nothing is hiding behind the cyst. And that's why, regular mammograms are still useful.
Thank you, Peter. Question about alcohol. I knew this would come up, Peter, that if alcohol is limited to the minimum, would there be still a risk for developing cancer?
Yeah. So right now our new guidelines came crazy, right? It went right down. And that's because if there's any alcohol, there has been an increased risk. Now, having said that, this is where we need to do better in our science, right? So in other words, if two people drink alcohol, the effect in their body is not the same.
Just like the vaccines, right? For example, we give 100,000 people the vaccine and 4 people get that heart thing, the myocarditis, but the rest of them didn't. So there's obviously something different about those people. And same thing with alcohol, I think. I suspect that there are people where they can process alcohol very well, in which case it doesn't cause harm. Other people, not so well. And we know that because people are missing enzymes. The people that get the red face and then they want to throw up, they're missing enzymes to process alcohol. So that one we know very well. So if they're missing enzymes to process alcohol, could it be that they're missing enzymes that now can't get rid of the alcohol, and therefore the alcohol can then do damage elsewhere? So we haven't done the genetic testing, but that's really what we want to do. Like, what's special about the people that drank a little bit of alcohol and then got cancer? Like, what's weird about their genetic makeup? And once you understand that, then we say, look, you've got these genes, you shouldn't touch alcohol. Whereas you have these genes and you can process alcohol, and so therefore you can drink. So that's why we have a mixture. So the guidelines say, let's just go to the lowest level where it's safe. And as you saw, the lowest level is really 0. I think that's what they're basically saying, is 0 is the lowest level, because there will be some people that even with one drink, you're going to have increased risk of certain cancers.
Thank you. I think there was a question about staging, the importance of staging.
Yes.
And the second question was, how does one follow up in terms of long-term, if, for example, prostate cancer, what would be the best follow-up?
Okay. So for follow-up for prostate, it's easier. So we use the PSA. So the original purpose of the PSA was to follow up for prostate cancer, to see if that number were popping up. And if it popped up, it means that prostate cancer was growing, or prostate cells were growing again. And then we made the leap of, if it's good for monitoring cancer, then why don't we do it earlier? And that's where we brought it forward and say, can we use it to screen for prostate cancer? And that's a very different kettle, right? Because now you're not dealing with everybody with prostate cancer and you're just watching the PSA go up. You're now screening people that might have big prostates and stuff like that. And that's where we got into trouble. So PSA for monitoring is still one of the best ways of doing it. In the future, perhaps imaging, so some of the PET scanning. So if you have metastatic disease with PET scanners, we can see increase in glucose metabolism in places where the metastases have gone. So that would be something useful. It's very hard to get PET scanners, but that would be another use of these things as well. In terms of staging and grading, these are just different ways that we try to figure out what level of cancer are we talking about. And in the olden days, it was very straightforward. Like, was it localized or metastatic? Because it gave you a decision. Do I just do surgery, or do I use chemotherapy? So if it's metastatic, then we basically do chemotherapy, because what's the point of taking this out? Having said that, now people now do different things, right? So they do chemotherapy first sometimes, and then they'll take out the tumor later so that they can shrink it, kill everything else around, and then take out the carcass, so to speak. So people are getting much more creative. And as we have better therapies for it, so we now have antibodies that can go after things. And then we have receptor blockers and hormone blockers. We're able to do much more in terms of running and chasing all these cancers down. Unfortunately, when they do the study, they have this stage, this grade patient, and then they follow them up. And so that's why the oncologist will follow that. So you're in this stage, so that we're going to follow this protocol, just like they did in the study. And that's the reason why they sort of stage, and you'll see it's very similar to the studies in terms of how they categorize these patients.
Thank you, Peter. The last question was a question about why do people who lived healthy lifestyles, despite everything they do, they can still get cancer?
Sure. And so therefore, yeah, that's a good question, right? So in other words, I want you to think about two things, right? There's the genetic code, which is what you're born with, and then there's the lifestyle on top of that. And I remember hearing one professor saying, sort of think about your genetics, like the DNA and stuff like that, loads the gun, and then the lifestyle fires the gun. So the two of those things probably work together. So if we got rid of all the bad lifestyle things, so no smoking, no alcohol, exercise, those kinds of things, if they have bad genetics, that's still going to drive them. So if they have those bad recipes, as we're talking about, right? So let's say in their DNA, they have bad recipes, and those recipes are being made into those proteins that, let's say, do not repair the DNA. So now, for example, Angelina Jolie, right? So she's got bad recipe. So she cannot repair her DNA when it gets damaged. And so she will accumulate damage to the point where there will be a cancer that pops up. So nothing to do with her lifestyle. She was just dealt with those cards. In the past, we were saying that we can't do anything for people like that because I can't go in and change the DNA. That's changing. So we have an ability where we could go in and cut out a piece and put in a piece. So people are working on that. Can we splice out a piece and then put in the piece that's proper? And then you'll be able to make the right proteins. But in an even simpler way, why do I want to mess with your main blueprints? The way that works is that the blueprints are sitting in a head office, right? Inside the nucleus. So then what we need is we make a copy of it. And that copy is called the mRNA, messenger RNA. So that copy goes to the factory. And that's the copy that will make the protein, the enzyme or whatever you need. So people thought, instead of going to the head office and dealing with this and trying to cut it out and break into the vault, why don't I just give you the mRNA that you're missing or that's defective, and then you would just make the protein. So this is why people are starting to look at the mRNA system as being a good way to short circuit this. So if you're not making that protein, I will give you the blueprints and then we'll make it. In fact, that was what mRNA technology was for. They just happened to borrow it for vaccines, right? They said, you know, can we do that with vaccines? But really, it was meant to give you back a protein that you cannot make. So you can understand now, for example, Angelina Jolie, she doesn't have the one that fixes the DNA. That enzyme is no good. Then could we give her this messenger RNA and therefore give her the right copy, in which case she can repair? Now, I've said a lot of things in the last 30 seconds, but it takes years to do that, right? And also, we have to have a way to continuously give those blueprints, right? Because if it breaks down in a day, then that means I have to inject you again and again and again. So we need some way to have that already built in. And so therefore, lots more research to be done. But you can see the direction that people are going at is that if you have a defect, we're going to try and help you correct that defect. And that might be the reason why you're having cancer. So even though you have the best of everything, exercise, alcohol, no smoking, if you had bad genes, that will still drive some of those cancers. Look in your family history as well, so you know what people are getting in the family. I know that sounds horrible, but if you look at older siblings and uncles and stuff like that, you can see patterns. Then at least let's make sure that we monitor them. So let's say you have bad genes and you are going to get some sort of cancer, let's say breast cancer, then let's make sure that we pick it off at the very, very early stages so that it's just a tiny little dot. Let's say you have a family history of colon cancer. Let's pick it off when it's a tiny little dot, and therefore it's going to take it another 5 years to build up another one. So by knowing that family history, we can then pay special attention. So even if you have bad genes, we can play Star Wars and zap the things as they come up.
Thank you so much, Peter. I know you have a flight to catch. We are so grateful to you for taking this time out to be with us and speak to us. A fabulous, fabulous presentation. Thank you and be safe, and we'll see you again soon.
Thank you very much. Thank you for the invitation. Your meeting is always a highlight, and your crew is just fantastic to work with. I have never met a bunch of happier people doing great work. So thank you all very much, and have a good evening.
Thank you, Peter. So, ladies and gentlemen, we still have a little bit further to go, and I want to welcome all of you to the Ripple Effect and the webinar outreach wing, and thank the committee under Smitha for their outstanding work once again. And I want to leave you with a word. The word is Ikigai, I-K-I-G-A-I. Iki means to like, and gai is alive. But this is a Japanese word that means more than that. It means to have a reason to wake up in the morning, a reason to live, a reason to enjoy your life. So if you have Ikigai, you will be motivated, you'll be purpose-driven, and you can have a life that is full of joy, full of energy, and full of purpose. So thank you very much, and I'm going to hand you now to Tina Walia.
Thank you so much, Dr. D, once again, for adding another meaningful and motivating word to our vocabularies. We cherish each one of them. Thank you again. And now I would like to take this opportunity to thank you, our wonderful audience, for your ongoing support and appreciation. We are proud to share our audience's feedback about our webinars through this
Webinars
short
from
video.
Ripple Effect Wellness have been good for my husband and me. The information is relevant and timely, the source is reliable, and the interactions are often quite lively. We find that spending time with both presenters and hosts have increased our gratitude for all the medical professionals who help take care of our local community.
My name is Jackie Briscoe, and I have thoroughly enjoyed the webinar wellness series. I've learned so much from it because they are experts teaching us about relevant medical issues, telling us about the how, when, where, and why. And I've so thoroughly enjoyed this community service that I've sent the link to my family in the Netherlands, in the US, and in Jamaica. Thank you very much.
I'm Ramesh Srinivasan, and I've attended several webinars put on by the Webinar Outreach Wing. These webinars have been informational, highly educational, and have been presented by first-in-class leaders in the medical and wellness area.
Hi, I'm Ayush Rao and I'm 11 years old. I've been volunteering for the Ripple Effect Wellness organization since I was 4. The reason why I never miss a webinar is because I find the topics that they cover very useful and informative, and they also help me better understand the problems people are having in my community.
Hi, my name is Radhika. I've attended many of the webinars held by the WOW team. One of my favorite ones was the one about COVID and the vaccinations. They were very well researched, very well thought out, and I always leave them feeling like I've learned something new.
That was excellent feedback. And once again, we thank you, our dear audience, for all the support and for attending each one of our webinars. Thank you very much. I would now like to invite our illustrious chair, Smita Chandra, to say a few words. Over to you, Smita.
Thank you, Tina. Hello, everybody. Thank you for attending the webinar today. We hope you enjoyed it. Thank you so much for your continued support and enthusiasm. Thank you, Dr. Lin, for sharing your knowledge with us, your vast knowledge with us, I should say, and for answering our questions so patiently. We have learned so much from you today. And thank you so much, Dr. D, for teaching us a new word in every webinar. But I think today's word is one of my favorites. Your words always have so much meaning for us. Thank you also for moderating the Q&A. Now, there's a lot of work that goes on behind the scenes, and our executive team works really hard to bring you these informative webinars. I would like to thank Tina Walia, Dr. Asha Devanation, Sridhar Rao, Ashima Jain, and Ashna Roy. Thank you all for your hard work and unique contributions. It is always so much fun working with you all. Thank you as well to our ambassadors who work tirelessly on our behalf to spread the word of our webinars throughout our community. If you have enjoyed our presentations and would like to support future webinars, please donate to our outreach through our website at www.trivo.org. Now, please help us serve you better by answering this quick poll. It will just take a few seconds of your time, but it will help us a lot in crafting future webinars. Thank you once again for spending the evening with us. I'm now going to hand it back to Tina. Thank you very much and have a wonderful evening.
Thank you very much, Smita. And once again, thank you very much to our audience for participating, being loyal supporters of our webinars. It encourages us and motivates us to do better, to bring you better content. And we hope to see you at our next webinar. Goodbye for now.